Bismillahirrahmanirrahim. Assalamu alaikum. This is Iman Mukhtar from 4th Prof Morning, having roll number BP1650087. I am from group number 39. My topic is adult parenteral nutrition, in which I will discuss case study related to the acute pancreatitis. So let's get started. First of all, what is nutrition? Nutrition is the provision to cells and organisms of the material to support life. There are two types of nutrition: enteral nutrition and parenteral nutrition. First, enteral nutrition, nutrition support by placement through the nose, esophagus, stomach or intestine. It can be done through tube feedings and must have functional GI tract. Number second, parenteral nutrition. The components are in elemental or pre-digested form. Examples: proteins as amino acids, carbohydrates as dextrose, fats as lipid emulsion, electrolytes, minerals and vitamins. The conditions in which parenteral route chosen is GI incompetency, critical illness with poor enteral tolerance. The typical disorders included are short bowel syndrome, acute pancreatitis, renal and liver failure, major GI surgery, multi-organ system failure, bone marrow transplant. There are two types of parenteral nutrition. The delivery of nutrients intravenously via the bloodstream. It can be done through two ways. Number one, central parenteral nutrition. It is also called as TPN, delivered in central vein. Number second, peripheral parenteral nutrition, delivered into small or peripheral vein, as we can see in this diagram. What are the problems or complications? There are two types of problems, either short-term or long-term. The short-term problems included fluid overload, electrolytes derangements, refeeding syndrome, hyperglycemia, hyperlipidemia, and infections. Long-term problems include liver dysfunctioning and osteoporosis. How can we monitor? General parameters including daily weight checking, vital signs including BP, glucose level, close monitoring, lab testing, circulatory proteins, serum electrolytes and lipid profile must be checked. What is acute pancreatitis? Acute pancreatitis is the sudden inflammation of the pancreas that may be mild or life-threatening and can lead to the multiple organs failure. As we know that our pancreas are the major organ because it acts as both exocrine as well as endocrine gland. The major basic functional unit of pancreas are the acinar cells. What are the causes of acute pancreatitis? Gallstones, which are 70% case related to the acute pancreatitis, are gallstone related. Alcohol use, drugs including ACE inhibitors, sulfa drugs, anti-cancerous drugs, hypercalcemia, hypertriglyceridemia, viral and others. Symptoms of acute pancreatitis included upper abdominal pain that radiates to your back, abdominal pain that feels worse after eating, fever, rapid pulse, nausea, vomiting, tenderness when touching the abdomen. As we can see in this diagram, that the pancreas are inflamed and also the bile duct is obstructed because of the gallstones. The other causes also included either duct obstruction, acinar cell injury or defective intracellular transport, which together can lead to the acinar cell injury by various mechanisms. And this acinar cell injury relates to the activated enzymes. This activated enzymes results in interstitial inflammation and edema, proteolysis, fat necrosis, hemorrhage, which together causes acute pancreatitis. Case study. The care of a 59-year-old woman is admitted to the hospital complaining of increased abdominal pain and vomiting. She is diagnosed with pancreatitis. This is her third admission for acute pancreatitis during the past year. Her past medical history is significant for ethanol abuse and chronic obstructive airway disease. A ING tube is inserted and she is to be NPO. IV fluids are begun for hydration. Over the next 5 days, KR's abdominal pain subsides. Her pancreatitis resolves and she started on an oral diet. 2 days after beginning an oral diet, KR complains of severe abdominal pain and is vomiting. She is febrile, her WBC count has increased to 21,000 per mm cube and she is hypotensive, requiring large volume of IV fluids. Furthermore, she develops respiratory distress and requiring endotracheal intubation and mechanical ventilation. Her most clinical representation recent included ABG is notable for PS 7.36, PCO2 is 51 mmHg, HCO3 is 28 milliequivalent per liter, PO2 is 88 mmHg. This clinical presentation is consistent with severe pancreatic necrosis. A small bore nasojejunal feeding tube is placed and enteral nutrition therapy is begun. However, KR develops severe abdominal pain and distension and bowel sounds are absent, so the enteral feeding is discontinued. The decision is made to begin parenteral nutrition because KR is not expected to have a functional GI tract in the near future and her nutrient intake has been inadequate during her hospitalization. What special considerations should be addressed in designing a parenteral feeding formulation for KR? Is the use of fat contraindicated in patients with pancreatitis? Soap notes are subjective. As we know that KR is 59 years old female, she is complaining acute pancreatitis with the characterization of abdominal pain and vomiting. She is significant of ethanol abuse and chronic obstructive airway disease. This is her third admission for acute pancreatitis in the hospital. Objective: the WBC count has increased to 21,000 per mm cube. ABG is notable for PS 7.36. PCO2 is 51 mmHg. PO2 88 mmHg. HCO3 is 28 milliequivalent per liter. As we can see that PO2 and HCO3 are in normal range. She is hypotensive, requiring large volume of IV fluids. Assessment: as the patient having increased WBC count and is febrile, so there is most likely to have bacterial or viral infection. Female is facing acute pancreatitis with the history of alcohol consumption and coronary obstruction. It's been likely that her vital organs are damaged, due to which there is lower BP because of the inflamed pancreas that allows cytokines to enter into the bloodstream. The gross examination of ABG results shows that female having respiratory acidosis and lungs are not removing enough carbon dioxide produced by the body. KR having GI incompetency, so enteral nutrition is not suited for her. That is why she is shifted upon parenteral nutrition. What is our plan? KR requires frequent total parenteral nutrition to decrease pancreatic secretion and for nutritional support. Triglycerides level must be monitored before administering the TPN and should be less than the normal. Lipids are not to be given if triglyceride levels are increased to normal. Serum glucose and calcium levels are need to be monitored. As KR is alcoholic pancreatitis patient, so there will be more requirement of micronutrients in the body. She requires folic acid 1 mg per day and a water-soluble vitamin preparation including thiamine 50 to 100 mg per day should be added in her prescription. Notes: if person having fever in parenteral nutrition, firstly parenteral nutrition must be stopped and figure out the infection, if any, either bacterial or viral. Weight changes are more likely to occur, so weight monitoring must be scheduled as it indicates fluid overload and dehydration. As our pancreas processes most of the fat we eat, so the more we eat, the harder our pancreas works. High fat food, sugar increases triglyceride levels, which eventually increases the chances of acute pancreatitis or either make it worse. These all are the notes which KR should follow for improving her acute pancreatitis. That's all for today. Thank you.